the last 25, 30 minutes with my topic of the top 10 trials of coronary intervention of 2021. Okay, so as you know, the interventional field started with Andres Grunzig doing the first PTCA, used to call, back in 1977, then 79. And he actually is the father of angioplasty. The dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patient, which I added with the utmost safety, appropriateness, and ambulatory. The majority of the patients go home same day. So this is my quotation on top. So I am going to present you data of last 1.5 years, which has changed our practice, made the significant impact. So we start with the first one, is the imaging trials. So many of them. So basically, when we do the angiogram, you see the coronary angiogram of the left upper top, but then sometimes it is not clear, ambiguous, but more importantly, to be more precise, we can look inside the artery by various devices. Ultrasound IVUS has been there, and there are criteria. What is the degree of blockage, whether left main or non-left main. Then a little more sophisticated called OCT, which is very, I would say, detailed images. You can tell you the thickness of the cap. And then the lipid, which is the NIRS. And Anu has done a lot of work with the yellow trials and many publications that lipid plaque is associated with a higher event rate. And then became physiological. Borderline lesion, should you do intervene or not intervene? And we do FFR or IFR. Basically, look at the gradient across the blockage. And then many studies have shown that doing intervention with FFR, IFR is better than just looking at angiogram. Now we actually have got done, those were more of the acute data. Now we actually have long-term data that FFR-guided PCI or angiographic guided PCI, and see here now, there is a lower mortality. So it's lower mortality with FFR-guided versus angio-guided. Clearly with angio-guided, you do less PCIs. Now question is why? It's because many times it looks 50, 60%, but this is a lesion which is probably lipid-rich, and of course will not dilate. And those are the ones then you identify FFR is positive, you put a stent. So key is many vulnerable plaque identification, reduce overall ischemia, decrease stent cost use, and that has been shown by 2 studies, and SCAR registry also the same way, showing that angiographic guided PCI versus FFR guided PCI, if FFR guided is better with a lower mortality. Now, the patient also, what is happening with FFR in the United States? As you can see, the PCI, FFR-guided PCI is increasing with a 75% at present, although if you take all comers, cath and PCI is about 20%. You say, why FFR-guided PCI? Many times you actually end up doing more revascularization compared to just with angio, because multiple diffuse lesions, which we say 30, 50%, they truly are hemodynamically problematic and create the trouble. And this is, again, similar data for the SCAR registry from United States. Mortality at 1 year, 0.6 in the angio-guided became half with FFR-guided. So now then question comes, you have done the good angioplasty, stent is good. Should you do FFR again or IFR to see whether your stent is working good? There are actually few trials have been done. One of them is the Target trial, that in half of them, they say physiologically guided incremental optimization strategy. That you did a FFR or IFR after the intervention, and it is abnormal, you went back, put additional stent and post-dilated, and turns out to be that overall, it didn't make difference. So this is the trial with the FFR, showing that slightly better, but not significant. So clearly, it's a pre-FFR good, post-questionable. This is actually ongoing trial called Define GPS, where IFR-guided PCI versus standard of care is ongoing at present, and we'll know after at least 2 years. Then, should you be using imaging during PCI? The IVUS guided many trials, and the ultimate trial, which is now showed the data of follow-up of 3 years, patients IVUS guided, yes, better, overall event rate lower in the red bar compared to the blue bar of the angio-guided PCI. Now then, we have 2 tests now, OCT, imaging, OCT and IVUS. Which one is better? There is a trial, a small trial, called Forger trial with the 1-year results. And what did they show? Basically, FFR guided versus OCT guided. There are clear-cut criteria how to do those numbers and so, and basically showed that overall, if you see here, FFR guided in the blue, the event rate point of view compared to the OCT guided. So OCT guided events rates after PCI were lower compared to FFR. So this is a small trial of about 350 patients, but this field is ongoing and we'll know a little more and in the coming future. And one of the important trials is Illumin 4 by my associate Ziad Ali, who was our fellow, is doing a great job, really whether we should incorporate OCT in our practice compared to angiogram. The second, the drug-coated balloon, which actually we don't have in United States for the coronary. We do have for peripherals, and there are many trials have come at this time, the use of drug-coated balloon, not the stent, drug-coated balloon, and many of them compared against the drug-eluting stent, and basically showed that if you have reblockage, restenosis after BMS or DES, so drug-coated balloon works better in the BMS, but in the DES group, it does not have that advantage. So DES, you have restenosis, you do a DES again. Your BMS, you have restenosis, drug-coated balloon works. And this is the central figure. So what about you do only is a small artery, drug-coated balloon or a stent? What is the data? Picoletter 2 randomized trial, again about 200 plus patients, showing that maybe in a small artery, drug-coated balloon slightly better. You see the height of the blue bar compared to orange. And this is actually in Europe, it's happening quite often. Small arteries, they are not putting a stent. They're doing a drug-coated balloon. But we don't have yet. The trials are just starting here. And so the overall advantage remains for the drug-coated balloon in the small arteries. There are a few others, other small trials in the past have shown the same. So momentum is there. And very commonly with a side branch. You put a stent in the main vessel, side branch do the drug-coated balloon, and that is what's being done. Now, only question is, drug-coated balloon, everybody aware of the fiasco with the peripherals that have a higher mortality when drug-coated balloons were used for the peripheral arterial disease. And question was that, is there any survival disadvantage in the PCI group with a paclitaxel coated balloon? This is the Prisma flow diagram. They presented the data of the numerous trials of the drug-coated balloon done for the coronary artery disease. And I'm PCI, and turns out to be drug-coated actually balloon was better. So what's the signal they saw in the peripheral arterial disease is not for the coronary arteries. And these are the basically showing the where does it basically work, drug-coated balloon, particularly benefit in patient with ISR. And the question is why? Lower DAPT dependence, less neoatherosclerosis, less adherent additional stent, and of course, less thrombosis with the drug-coated balloon. And we are eagerly waiting drug-coated balloon to come. And here is the topic of the colchicine and stable ischemic heart disease, the inflammation. LODOCO 2 trial has been very elegantly shown by our speakers and of course Dr. Libby being here. So key is that anti-inflammatory really coming into the interventional field. We have the trials of using colchicine in acute MI. And it works on various factors, the platelet inhibition also, adhesions, and basically Colcott in the acute MI, showing colchicine 0.5 milligram daily. Only problem is in America there is no 0.5 milligram, it's 0.6. But in the trial was used 0.5 milligram, overall showed in the acute MI population, colchicine red bar was better. And then in a stable coronary artery disease, does it make sense? And again, the large number of patients, about 500 plus, stable ischemic disease, were randomized to colchicine 0.5 milligram daily versus placebo. And as you see, in every point, there was a benefit. Question is the death is a separate, but otherwise, the less angina, less revascularization. So clearly, the patients who are refractory, symptomatic, ischemic heart disease or acute coronary syndrome, they will benefit from colchicine. Now, issue remain two things with the colchicine. One is the infection, and there is a little signal of higher death rate. Means not significantly, but a little signal. Is it because of the infection, they develop pneumonia, various factors still need to be seen by which look into see the non-cardiovascular death, 0.7 versus 0.5%. And then all the trials you put together, they actually meta-analysis showing that lower MI, lower stroke, lower coronary revascularization, and cardiovascular death is unchanged. So basically, and the various mechanisms of the colchicine shown here. So seems to be, it's a good agent now in our armamentarium, and I can tell you I have started using it now for last 1.5 years with the moderate success, not a great success, but moderate success. But I'm talking about patients who have multiple interventions, they're already on multiple anti-ischemic drugs and so. Then revascularization, low ejection fraction. Remember, low EF patients have been, there are many trials which have compared PCI versus CABG. But patients with a low ejection fraction have been excluded. Now we actually have some data that this is the Ontario database, ejection fraction less than 35%. They followed the patients, PCI versus CABG, not randomized, but those who got PCI and CABG and basically saw big difference in favor of CABG. Low ejection fraction, patient did better with CABG at long-term follow-up of 8-10 years compared to PCI. And these are the individual endpoints, so it makes sense, since we don't have any randomized trial, patient multivessel disease, your decision is CABG versus PCI, low EF should be, I would say, selectively pushed towards the CABG than PCI. Also in the left main, this is the study from Iris Main from Korea, a similar kind of message also occurred in that. Basically, patients with a low ejection fraction, severe LV dysfunction on the right side, have advantage of CABG versus PCI. In other group, there was no difference. So seems to be left main, complex disease, low ejection fraction, better for CABG. Then disrupt CAD3. What it is? Calcific lesion, we have few devices, and one which we commonly use is the rotational atherectomy. But it's a very technical device, require a lot of training, steep learning curve. People are concerned to use those devices. So now there is a simple solution for a balloon. Intravascular lithotripsy, we call IVL, and basically the concept is that you do acoustic waves into the coronary, so anybody can advance the balloon. It's a little stiffer balloon, so you may have to make a room for it, but it's a simple, it does not need technical, you don't need much learning. And this is a shock wave, and acoustic pressure waves fractures the calcium, severely calcified, has been shown by the OCT, IVUS, by the Disrupt CAD 1, 2, 3, and 3 was done in United States. Here, again, not a randomized, but overall just a prospective registry of 400 patients, or the excellent results, safety point of view also, no perforation, worked quite well, and more importantly, that the endpoints were, which is acceptable for any new device, actually better than that, with a great success rate of 92 to 94% various ways. So clearly the FDA approved it, and now it's available. Only one issue remains, it's an expensive device. Cost is about $4,700. We still don't have a reimbursement for it yet. They got a little code about 2 months ago, about $1,500, but cost still remain. And compared to comparative, rotational atherectomy costs around $1,400, which is for calcific lesion. So where it will fit in, but the company actually went public about a few months ago with a value of about $6 billion. And it's just approved in United States, but it has other uses also with the renal stones and so on and so forth, and peripheral arteries. Then we have many trials of the DES has become kind of a default strategy. We don't use bare metal stent, whether it's acute MI, vein graft, anywhere. And there are many trials that still keep coming that whether one stent is better versus other stents are better. And because it's the combination of the drug carrier, stent design, and pharmacological agent, and a few trials have shown that equal results. And one important issue that with the DES era now, whether you have a LED lesion or non-LED, you can see here the overall outcome of the patient with the proximal LED and non-proximal LED is similar. So DES works very well in the large vessel. Then 2 comparative stents, Bionics and Neuris, showing the similar outcome. Only one was the combo. There was a combination stent, and that actually failed against Orsiro. So I don't think that will be available will come to the United States. Again, another comparative trial of our stents, which we use Onyx versus Orsiro, similar. So what also came up is, what about the polymer-free stents, particularly patients who are at high bleeding risk? So therefore, you don't have to give depth for a long time. This is the Onyx 1 trial, which compared the DES, Onyx versus Biofreedom DCS, which is not available, drug-coated stent, and basically showed that you give 1 month of depth, 1 month, and similar outcome. No increase in stent thrombosis or so. So seems to be this field is ongoing, but comparative, but I think by and large, all stents are equal. This is our data at Mount Sinai with a large registry comparing Zion's Promus synergy in all cases. In complex cases, we defined them, and overall stent thrombosis was identical. Seems to be the stent basically has leveled the playing field, and by and large, all stents perform equally good. Then left main update. You remember the left main, the trial of Excel, which compared in the low to intermediate risk STS, the syntax group, to PCI with the Zion's stent versus CABG, and the data basically showed 3-year were identical, 5-year data presented last year, and this showed the basically overall, while the outcome remained similar, but clearly 3% advantage at 5-year with the CABG compared to PCI. But what bothersome is what happens after 1 year. You see here, first month, PCI better than CABG. 1 month to 1 year, equal. But after 1 year, the curve just starts separating in favor of CABG versus PCI. So what will happen at 8th year or 10th year? So that's where concerning is that even in the not high or complex left main, where the syntax was less than 32 or below, that there is a clearly advantage of the CABG in this patient. So it seems to be that we need to be careful when we make a decision and make the recommendation to the patient. And these are the individual endpoint. And what really bothersome was, and that was a big lot of in the news, that higher mortality, significantly p-value makes it now at 5 years, 13% with the PCI and 9.9% with CABG. So clearly we had to tell patients who still want to decide for PCI or CABG these patients that these are the data we have. Other endpoints were similar as shown here. So this actually has been a very controversial topic, that does PCI cause more death in patients with unprotected left main? And since then there have been many meta-analysis and basically showed once you combine with the meta-analysis, there was no difference in cardiac death or myocardial infarction. Yes, revascularization was a little higher, but definitely hard endpoint in the meta-analysis, including Excel trial, was no difference in MI or death. So this field still remains. I think the jury is out there. A selected patient, I would say, where left main could be well indicated. More important is for once you do a left main, practice makes perfect. Means those who are high volume operator, they have almost half the mortality compared to the low volume operator. So clearly you need to go to a place, once you have a left main disease, to go operator with a high volume, and more importantly, use the imaging. It has not become the guideline as a class 1, like 2A. At present, that imaging guided left main intervention, and we actually, Mount Sinai is not a big imaging lab. We do a lot of FFR, like 65% plus, but imaging we do in less than 10%. But cases, left main, unless there is some contraindication, always do imaging in those cases. So imaging-guided left main intervention has shown to be a better outcome, and these are the guidelines. Again, still old, from at least Europe point of view, low syntax score. PCI is still become the class 1 indication, while not in the United States, because those guidelines are still far away. But clearly, high syntax score patient with left main goes for CABG. Low to intermediate, appropriate patient could go for PCI. Then prospect trial and absorb trial for the high-risk plaque. Basically, that vulnerable plaque, what is the natural history of a plaque in patient with acute coronary syndrome? You have taken care of the lesion, and now other lesions, you follow them, what happens to those patients? And those are the prospect 1. And the same was extended into the prospect 2 using infrared spectroscopy, because it was the IVUS in the prospect 1, and here was IVUS as well as the infrared spectroscopy. Same catheter can do both, and that was the prospect 2 trial, and basically identifying that what is the predictor of subsequent event in these patients with who are acute coronary syndrome. As you see here, prospect 2 trial for the natural history point of view, now published in Lancet few months ago, 900 patients with troponin positive after successful PCI. And then you did a 3-vessel IVUS, and if there's a significant lesion, you did FFR. If FFR is non-flow limiting, it means FFR was more than 0.8, so you cannot do PCI. is not indicated. So those cases were looked into and subsequently followed, enrolled in the study. And with more than and the plaque burden has to be more than 65%. So also within there, a small group, they randomized to absorb BVS, which is not available now. As you know, BVS, which is the bioabsorbable stent, had a more complication, but that was done part of the trial in this small sub-study of the Prospect 2. And basically what they found, that patients, even after you have taken care of the acute, if you see the event further on, in this day and age with a good stenting, most of the event occur from the non-culprit lesion. And mind it, all these patients are treated aggressively with various medical therapies. So event rate of 13%, 2/3 of them occurring from the non-culprit lesion, the lesion progression. And these were the non-obstructive lesions. And then, of course, if you put into the equation that they have a high lipid content of 324 or plaque burden of more than 70%, the event rate is 7% versus could be 1%, 7 times higher. Non-obstructive lesion angiogram, negative FFR, the 7% event rate. So just to say that there is something to the plaque morphology inside, and these were the individual lesion level predictors, which is the lipid core burden index, plaque burden, minimum lumen area. And within there, as I mentioned, the nested randomized trial of the absorb BVS versus guideline directed, that knowing that there was no clinical indication of PCI in these cases. But should you put absorb stent and patient absorb, it will be gone in 2-3 years, or should you just follow them? And this is actually very interesting. What happened is that once you put the absorb stent, that your lumen remain better, which we expect with the absorb. Unfortunately, absorb stent is not available. So MLA, which is minimum lumen area, was 6.9 versus 3. 3 was when we started. And then second point was that event rate. With the absorb, it was 10.7, and with the guideline directed medical therapy was 10.7, and we went down to 4.3 with the absorb stent. So more than 50% reduction in event, like almost 60+%. But just to p-value was 0.12 because small number of cases. But the concept is there, that high-risk plaque, non-obstructive, if you can perform a stent with a low complication and stent which will dissolve in the future, maybe the way to go. And you know, the absorbable stents are coming back into the market again. Many of the trials are ongoing at present. Then the P2Y12 inhibitor trials, comparative, some of them which have been asked earlier. The one was the comparing the clopidogrel with ticagrelor, and this was the Alpheus trial of 180 milligram ticagrelor with clopidogrel, and follow-up. Clearly by ticagrelor, you have a better platelet inhibition, but overall clinical outcome of the MI, death or stroke was identical, but at the cost of, you can see here, that the overall event rates are identical in all, but you have higher bleeding. So now, with the current generation stent, you have higher bleeding of the ticagrelor 11.2, BARC 1 or 2, small, minor bleeding, not the major, but trend was there, even in the major bleeding, 0.5 versus 0.2. But key is that should we be using clopidogrel versus ticagrelor in all patients? So this trial shows that maybe the clopidogrel is good enough, 2,000 patient trial. Then comparing the same thing, clopidogrel against prasugrel, and this was one of the questions was asked earlier, which is Sasikia trial, and basically showed the same outcome. Ischemic outcome was similar, but lower bleeding rate, and so. So seems to be that there is a tendency, if you go to the clopidogrel group, lower bleeding and present, compared to the Plato and other trials which we did in the past, so where the clopidogrel was inferior, but that was a different technique, different stents. The current one are totally different. So these are the pooled analysis of both the trials, overall showing that clopidogrel definitely has an advantage, particularly in the bleeding point of view, while ischemic remains. So also another trial which looked into the patients more than 70 years of age with the acute coronary syndrome, where recommendation is use ticagrelor. So or prasugrel, so that is what they did, and compare against clopidogrel, and basically showed the same message. On the right side, death, MI, stroke, identical at 1 year, but lower bleeding using clopidogrel. So, well, we have all the trials, Triton, Plato, made it class 1 indication in acute coronary syndrome. But now all of a sudden the trials are being done showing that clopidogrel may be as good and rather lower bleeding. So many trials will keep going on. Other question comes, maybe you do a high intensity for 1 month and go down. This is the trial called Polytech ACS trial, the de-escalation. Prasugrel you give 5 milligram after 1 month compared to 10 milligram, and basically showed de-escalation of 5 milligram is better. And those who know me, I'm using 5 milligrams since 2012. The trial showing now, the 5 milligram is better. We only use 10 milligram patients who are more than 100 kilo. So clearly, the small dose of this agent, particularly prasugrel 5 milligram, is good enough, associated with the lower event rate and, of course, the lower bleeding. The most important trial, part of them has been covered by Dr. Roxana Meran, is the DAPT duration trial of last 1.5 years. Zion's, Master DAPT, ACS2. So Zion's short DAPT program basically was that patients who are high bleeding risk, can you cut down your DAPT to 1 month or 3 months? They have clear-cut inclusion criteria of the high bleeding risk patients and gave 1 month or 3 months of DAPT. And basically trial design was using the Zion's stent and subsequent follow-up. And overall data showed that what were the high bleeding risk criteria? Most of them had 1.5 to 2 criteria of the bleeding, and showed that comparative, again, it is no randomized, comparative, that clearly Zion's 90 on the left side, Zion's 28 on the right side, you see identical outcome of the death and MI. But at the same time, our purpose was in this high bleeding risk patient, do you have a lower bleeding? And answer that is yes. You get a lower bleeding as shown in the 2 to 5, 3 to 5 grade of bleeding, significantly lower by the shortening the depth duration as shown here. Then are you going to cause more stent thrombosis? Answer is no. With the trials, stent thrombosis was, as you can see here, 0.2 to 0.3%, which is what the historical being there. So based on these data, FDA issued 1 month DAPT indication for Zion's DES on June 28, 21. Roxana actually has published the data from Sinai also, same. The patients who are high bleeding risk, more features you have, 1, 2, 3, 4, you have more chance of bleeding post-PCI. Majority of them are on clopidogrel, but more chance of bleeding. And once you have more bleeding, look at the right side, all-cause mortality in MI is much higher. Why? Because many times when you bleed, you stop all the medicines, particularly DAPT. And this is clearly, I would say, the force at present has been that cut down this anti-platelet therapy. The major trial was presented in the Master DAPT in European Society of Cardiology 2 months ago. And basically, in patients with high bleeding risk, you did an abbreviated DAPT versus standard DAPT duration, and 1 month versus longer, and basically showed important endpoints. Net event of the ischemic and the bleeding was in favor of 1 month. Ischemic endpoints were no different as shown here, but most importantly, the bleeding endpoint all showed lower side. No difference in stent thrombosis. So abbreviated DAPT of 1 month was superior to continuation for 1 year. And look at the major clinical relevant bleeding from 9.2 down to 6.4 in high bleeding risk. So shortened time duration is better. As shown earlier, stop DAPT2 when you do acute coronary syndrome. You say, let's do this in acute coronary syndrome also. We got very good with the PCI. What about we do it for only 1 month in patient with acute coronary syndrome? This was a little complex trial, and they did imaging in many of them, used different doses of prasugrel, and so basically showed that 1 month versus 12 month, there was slightly, 12 month has a little bit numerically lower 2.8% event versus 3.2 means 0.4 lower, but non-inferior. But look at if you do a bleeding issue, yes, bleeding was lower in the 1 month compared to the 12 month. But if you say death, MI, stent thrombosis, stroke, there's almost 1% lower in the 12-month group compared to 1 month. And you put it together here. And more important is the MI. So in acute coronary syndrome, PCI, you decrease the depth for 1 month is bad. While in stable syndrome is okay. But in patient with acute coronary syndrome, you need to continue longer. As you know, guideline at present is more than 6 months. 6 months to 1 year. I mean, 1 year basically. So we continue. So yes, while we can decrease the DAPT in high bleeding risk cases, and more importantly in stable syndrome, but not in the acute coronary syndrome, as shown by this STOP DAPT2 ACS trial. This actually has been incorporated in the guideline, has been shown there. And then another trial from Korea was that do 1 month versus 6 to 12 months, showed similar outcome, but they were all more of a stable patient. So just to say, this field was very flooded of the antiplatelet therapy, abbreviation, de-escalation, last 1 and 2 years. The Twilight type trial, the ticagrelor monotherapy, compared to the same trial of the Twilight, that after 3 months, you knock out the aspirin, and clearly the monotherapy did better. We actually have now prasugrel also, monotherapy, no aspirin. And seems to be the trials are ongoing at present. So key has been that cut down the DAPT duration, cut down the de-escalate, and take the aspirin away. And that is the most important advance of us as an interventional cardiologist. And I'll put it together as my central figure. What did we learn? Basically, various DES types, drug-coated balloon in the ISR, left main PCI, 1 month DAPT in acute coronary syndrome, kind of neutral, maybe negative. IVL, high-risk plaque on NEARS, BVS for high-risk plaque, de-escalation of antiplatelet therapy, thumbs up. We're changing our practice. Imaging-guided PCI, colchicine coronary artery disease, cabbage in low EF, clearly 2 thumbs up. FFR use, short DAPT in high bleeding risk, aspirin 1 to 3 months PCI, multiple thumbs up. And that is where the guidelines should change, because practice pattern has changed already to become the better interventionalist. And this actually, we don't have the data of 2018 yet, but Mount Sinai being the #1 in volume and the safety since 1994, since the data have come, and with the significantly lower readmission. That is also one of the important points. And I'll just finish it here to say, overall, the power of medical therapy. And despite all the trials which we have done for the complexity, so you can see in last 16 years, the overall volume of PCI or cabbage has declined 40 to 50% in the United States. You say, maybe cabbage should go up with the complex cases. No, all have. Why? Because the power of the very good various medical therapy, guideline-directed medical therapy, and many of those important topics which we talked today. It's not necessarily the devices, it's basically the overall in number of the procedures, the revascularization procedures, PCI or cabbage, continues to decline. It seems to be the latest data have come, that it has kind of stabilized now in last 2 years, but these are from the STS data at present. We still need to wait for the PCI numbers, that may be a slightly 1 or 2% increase, but after the significant decline in the last 14 to 15 years. But it's a very exciting time. This field continues to evolve to make us a better operator, and that is what we want to do, to improve overall patient prognosis. And hopefully, today's conference came handy, useful to all of you, and we brought the latest in various fields of cardiology. Although it's a top clinical, there are some non-clinical, interventional topics also, but idea was to bring you the latest and greatest in this field. And thank you very much, and I'll stop here.